You're listening to Finn Voices on Healthcare Now Radio, where we highlight and amplify the voices at the forefront of health innovation. Innovation that improves people's lives. Join us for an inside look at the changemakers driving conversation and answering the most important questions in healthcare today.
Welcome to Finn Voices. I'm Beth Friedman, Senior Partner at Finn Partners, and joining you today from Atlanta, Georgia. Today, I'm actually thrilled to welcome Meghan Harris. She's President and Chief Operations Officer at Acentra Health. Meghan brings a fascinating background in mathematics and statistics. She's incredibly passionate about whole person care, whole population care, and the community drivers of health, which we're going to talk about today. We're also going to discuss how the industry is using health analytics to identify community needs, uncover care gaps, and design more effective interventions across the community. Meghan, welcome to Finn Voices.
Thank you for having me. I'm excited to have this conversation with you.
Yeah, same. I live in a relatively small community outside of Atlanta. So we're Atlanta suburb, but we are a smaller community.
Yeah.
So I'm super excited to dig into this topic. There's been a lot of interest for maybe even the past decade on this topic.
And topic's been around for a while, and I think we keep evolving how we think about it. And the smarter we get about what actually impacts healthcare, the more the topic keeps evolving. So I'm not surprised it's been around for 10 years.
Yeah, for sure. So before we dive into it, tell us a little bit about yourself and actually tell us what brought you to Acentra Health.
It's a good question. So I have actually been with Acentra Health for over 20 years. The company has clearly changed, and I've gotten to do a whole host of different things, which is really exciting. But my background is really in data analytics, statistics, health service research. My family has always been in the healthcare field. I myself and my brother and sister were diagnosed with a rare disease really early on in life. So genetics, health service research, how, I ended up having to have a liver transplant from that disease. My brother and sister didn't. So it's always fascinated me just how different kind of healthcare situations impact individuals very differently. I had the opportunity to join Acentra Health pretty early on in my career. And it's a company that really was studying how different communities were receiving healthcare and what were some of the barriers. And it spoke to me, and it still speaks to me today.
Very interesting. Very cool. So that I didn't realize when we were preparing for the liver transplant. That's huge. Wow. That really is huge. And the interesting thing that your siblings did not need it.
Yeah. It's very statistically very unusual. So the stats background got pulled in pretty quickly when trying to figure out what that actually means. But, it's, I'm very blessed. I've had a host of really, powerful people in my lives, powerful doctors, powerful situations. And I'm really blessed to be where I am today.
Yeah. Well, congratulations on that, I guess, right? So let's get into the community conversation, because that's really why we're here today. So when we prepped for this, you really told me that you believe the best work is done when it's steered by the community and the members in the community. And that could be providers, that could be other stakeholders. How can we as an industry do a better job at designing programs and interventions with these community needs in mind?
I think what we end up doing is making the mistake of creating programs at different levels. So you might have a state program or a county program or a federal program, and then we wonder why we miss the outcomes of the programs, right? And so these programs are amazing, and we need to have the infrastructure built by the federal and state and county governments. But each county, each situation, each zip code, in fact, is very different. It's different from an access of care perspective. It's different from prevalence of healthcare issues perspective, socioeconomic, and even just social norms that impact somebody's healthcare. So while it's really fantastic to have federal and state funded government programs, they really need to be dialed into those communities where everybody experiences healthcare differently.
So I probably should ask you this question first. Tell me, because when I think community programs, I think of things in my community that maybe they might be hosted by my hospital here in town, Northside, but it might involve the food bank or the shelter or the the thrift stores or some of the volunteer programs here in our little suburb. Is that what we're talking about when we talk about community?
Yeah, that's the community. That's the community who knows what that community needs, and they have, the community has put those things forward. I think we make the mistake of relying on state and federal programs, and quite frankly, those state and federal programs should be relying on the communities, funding those areas, funding those food banks, funding those, in a way that's actually meaningful to move the needle with folks. So I think it's community designed, right? So those communities know what their communities need, and we need to make sure the programs that we're creating and working with are really focused on engaging with the partners in the communities that really know what that specific zip code, county, area really needs.
So this is going to sound like probably another too simplistic question, but
Sure.
when you're thinking about these community stakeholders, who are the participants? Like, is it the I don't know, is it some kind of community government office or more like a social services
I
office?
think it's a little bit of both, right? So sometimes it's the county health departments put on quite a bit. Sometimes it's the areas on aging that put on community things. Sometimes it's your churches and schools, right? So it's everything from something that's pseudo government to things that are just truly based. I've seen, I participate in the food bank down the street from my house that is, just a community food bank, right? So I think it's all of the above. And I think that's why it's hard to sort of manage or put your hands around when you think about some sort of government funded program or commercially funded program, because it is so nuanced to how to, then leveraging all of those really specific programs in the different communities.
So it's much more grassroots.
It is. I think they tend to be still very grassroots. Yeah.
Yeah, very cool. Yeah, I'm actually very involved in mine as well. I
Yeah.
volunteer at the homeless shelter every Sunday, and yeah, it's church sponsored, but there's so much community involved.
Yeah, it's about the community though. It doesn't have to be. I mean, most people show up, where I'm from and probably where you're from. Most people show up for that with just an open heart to help people. And whether it's government, church, school, it's an avenue for most people there just trying to help their community and help their neighbors.
Super exciting, super exciting. Okay, now let's tie together
Yeah.
all this community conversation with something that I talk about a lot on this show, which is data in healthcare
Yeah.
data. How do we connect all the data we have, no matter where it's coming from, I guess, because it comes from everywhere,
Yeah.
with these communities that need to build these programs so it can inform them, right? So it can help them.
Yeah, I think that's where earlier when I mentioned state and federal, that's who has a lot of the data right now. And so how do you get it in the hands of the people that can actually, do something with it to help improve outcomes, health outcomes, socioeconomic outcomes in a community? And so there are programs, there are states, there are, databases and things like that are out there that are accessible, but it's not an easy thing to be able to go and get and do. But if we're going to actually improve the healthcare at the community level, which is I think we absolutely need to do to move the needle, we have to get the data in the hands of the people that can actually design programs at that level to improve health.
And what kind of data? Is it mostly just demographic? I guess maybe not necessarily because you have clinical stuff as well, right?
Yeah, I think it's more. I think it's demographics around individuals. It's about their healthcare, disease prevalence. It's about also access. Access is such a big issue, and that's access to certain kinds of physicians, certain kinds of emergency care, certain kinds of as food banks, certain kinds, like not you can design a program and say this is what this community needs, but if that community doesn't have access to any of those things, that program will not work. And so you have to kind of design programs that looks at what's available in the community and how do you match people to those resources. But you also have to design programs that really fund potentially the types of things that might be missing from that program or from that community. I'm sorry.
So that leads me really well into a kind of a complementary topic here. As we look at these programs in the community, as we look at sort of these individuals in the community, the goal now, and what we've been talking about for a few years, is whole person care.
Yeah.
So not just looking at maybe somebody's diabetes, but looking at everything that's impacting that patient. So talk to me a little bit about the concept of whole person care. Let's start high and then we'll get down into the weeds of it.
Yeah, I think you have to look at everything about that person that impacts their ability to get and succeed in a healthcare environment. And succeed means it's a norm to do so, right? So sometimes what I found out very early on, and I'll just do it one quick note about when I first started with the company, I worked on a project that really evaluated why certain zip codes didn't get mammograms, even though it was publicly available to them. And we did this really started my fascination with this topic. We found that there are communities that didn't trust the healthcare system, or the mammography centers were open 9 to 5, and bosses didn't let people out for work, or grandparents were taking care of kids, and so they weren't able to get there. So it's really driving down to the level of understanding of everything about that person that might be keeping them from engaging in the healthcare system. Now, where is the data for that? A lot of socioeconomic data, a lot of health, current healthcare trend data. It's also access data where, is there hours even? It's not just, do you have a mammography center? What are the hours? What's available? So it's got to be all of the information. And that it all distills down to a data set. It's, pieces of data. It's just getting them in the right hands so that you can make the right choices.
And getting them together.
Yes, and getting them together. Yes, absolutely.
Always our problem. Always
Yes,
silos,
yes.
right? Or silos in healthcare. So whole person health again. So we've talked about the need to look at that. Like you just said, it's one thing to have the data, but it's quite another to have it in the right hands where they can actually design the programs with the whole person in mind. So, and we talked about the specific types of data as well. Logistical challenges, I think, I don't know, I feel like we all kind of know what those are.
Well, I think it's twofold. Beth, I think one of them is designing the programs with the right data, but then getting it in the hands of the people that are actually interacting with that member is the number two part of that, right? So one is, let's make sure we have programs. Let's make sure we're putting dollars, investments, understanding of what's available and everything about that person and how do you match it. But it's also making sure that's in the hands of individuals. When you go to the doctor's office, do those people understand what the community has, what your needs are? Who's the trusted advisor for that member or beneficiary or person in general? It could be a case manager, it could be a doctor, it could be a church, right? And how do you get the right information in the right hands to be able to distribute it? Because I think that's equally as important as it's making that human connection. Starting a program is great. It's funded. Someone's going to come, people are going to flock to it, but there's also people who won't because they're not going to engage in it unless a trusted entity to them will engage, lets them know that it's available.
And these kind of roles, whether they're employees of a health plan or of an FACQH, they're in, high demand, short supply, just like the rest of
it is. It's very difficult. We've gone from nurses to social workers to community navigators now, which I absolutely love because I would rather have somebody from the community who sounds the same, looks the same, feels, it understands the street names when you're saying go over here to go find something. I love the idea of the community navigators. I think they became very much more in vogue during the COVID process, right? Because you were trying to get people, it was, really highlighted the whole person and socioeconomic differences that we had in healthcare. And I think, and it doesn't have to be a highly skilled individual, right? It provides jobs in the communities, right? For people. And so I think there's ways that we can get this even with a shortage, because I do think there's a shortage of nurses and clinical workers in general.
And I think about even myself, right? It's all for other healthcare workers and all the other ancillary areas. It's something to think about as far as a job that's kind of probably half volunteer.
Yeah.
But, half paid, but at the end of the day, it's truly helping humans, right?
It is. But I think through, I have an elderly parent and I'm trying to figure out community resources to provide for them for things. And I don't know where to go. And I'm in healthcare, right? So imagine, and I know who I'm supposed to call to go find those things out, but imagine you don't navigate the healthcare system on a regular basis and to have an entity or a person or somebody trusted you can go to say, hey, I'm having this problem. What do I need to do for that?
You just mentioned your personal example with your parents. Let's talk about some other examples. So what have you seen during your work with Acentra? What are some programs that you're seeing that are highly valuable, really making an impact in the communities?
I'd say there's two. I mentioned COVID earlier. We did a program where we were really trying to ensure the right people were getting vaccinated or the highly high risk individuals getting vaccinated. What we found in doing that was that they had a bunch of other socioeconomic needs. They now, didn't have rent. They couldn't pay rent. Their jobs were shut down, and all these other things that came across. And so what North Carolina did really well was empower us to also work with community resources to connect those people. So it became not just about a COVID vaccine program, but it really became the basis for their Healthy Connections program they have now. But it's really became a community-based program, and we embedded people in that community from those communities who knew the people at the grocery store today, set up tables at the grocery store about where they could find resources and sign up for resources, because that's the level of detail that we had to be at. The other one that was really interesting was the state of Oregon. The state of Oregon has very challenging climate concerns, so fires in particular in this case, and we helped them really look for individuals who had COPD or other type lung and breathing issues who were going to be impacted by climate issues such as the fires. We work with them to deliver air conditioners to their households, so they didn't have to have the windows open when it was the dead of summer. And so what a creative program to put on by a state to really know their population, know who's going to be impacted, and have a solution that is not just clinical, right? That was a non-clinical decision-making intervention, but so much impacted the clinical and health of those individuals.
Very cool. So I love the air conditioner idea.
Yeah.
You ever watch, what was it called? Not St. Elsewhere, it was a show about a charity care hospital in New York City. It's not on anymore, but they always came up with these creative solutions.
Interesting, innovative ideas, right? I certainly didn't come up with, but they knew, there are smart people out there who come up with these really great ideas. Yeah. It was like, we're doing air conditioners. And then I heard the kind of clinical, I'm like, makes total sense to me. Like, we should definitely do air conditioners.
So I'll be the devil's advocate here. Yeah. Been in healthcare a long time, so sometimes I go there. Funding for these things funding and also return on investment, right? Proving that these types of interventions that are very holistic, very human, have a financial return. I think that's always been one of the biggest challenges. Is it still that way?
I think it is. I think because it's long term. So when you're thinking about commercial programs or like my employer's healthcare program, unless I'm staying with my employer for 10 or 15 years, they don't see the benefit of some of that early health, preventative health, or other kinds of things, right? Because I may have left and went to another job, and so somebody else is benefiting from my good health care. So that's on sort of the commercial side, but the same is very, very true on the more on the community side too. The impact is really, really, really long term, right? So you're healthier, you're not getting charity care by hospitals and facilities turns into more higher rates for, paying insurance payers. Like, there's this vicious circle of things that occurs that we all end up paying for anyway. And we have done measurements. There's absolutely health economics papers and out there that show this overall benefit to the community and to us, all of us. But we're not patient. we're not patient. So we get that we're not going to fund you unless you can show me something in the next 2 or 3 years. And some of those impacts aren't 2 and 3 years long, right? Some of them are, but often the impact on us as a society are much longer based. And we're, unfortunately, we aren't, those are university level studies that are studying longitudinal data for a very long time. And these programs are really designed to try to show an impact in the 2 to 3 year range. And it's just so much harder to do.
Sometimes that's not enough, right?
Yeah.
Actually, you and I talked about one that you said there was, obviously an issue with, and that's in my state of Georgia, the maternal health program, that perhaps we focused too much on the health of the baby and didn't look at the whole person in that situation is also the mom, right?
Yeah, I think it's interesting that we start focusing on the baby, the baby's healthcare when the mom shows up, probably already in their second trimester, right? And so the maternal health is really when that mom is 10, 7, 8, 9, 10 years old, right? Unless you're going to address the mom, I think, we're going to continue to see our lower maternal health rates. I think it's unfortunate. It actually makes me very sad that we as a country, and Georgia being one of those states, can't figure out how to take care of again, because you can't start 3 months into a pregnancy and expect the baby to be healthy. You just can't. I think it's unreasonable.
Back to that long tail, right?
Yeah.
Like you mentioned, like maybe with women, yes, it starts as young girls and educating
Yes,
them in
absolutely.
schools about, if you ever get pregnant, here's what to do. All these things, right? Yeah.
Yeah. It's you have to start early. It's the health of the mother is probably the number one impactor of the health of the baby. And so again, starting 3 months into that process is probably a little late to really.
Not
I
gonna
mean,
make
obviously there's still stuff you can do, but you're not going to get the best outcomes.
Yeah, for sure. For sure. Thanks for sharing that one with me because that's one that's near and dear to my heart.
Yeah.
Involved in a lot of conversations here in Georgia, and we talk about it all the time.
Yeah.
And we get frustrated, obviously, with
Yes.
it's not.
It is
We've not
very
moved the
frustrating.
needle. We're still like
Yes.
one of the worst states for maternal health, which
You know
is
what's frustrating is that we know what to do and yet we still aren't doing it. And I think there's some, when a system or process is so, I don't say broken, but it's probably, or disconnected from each other. It's frustrating to see. You can very clearly see what needs to happen, and yet we can't seem to make it happen under our current healthcare system, and that is extremely frustrating.
It's funny. Even as recently as a couple years ago, I was meeting with a coalition of our children's hospitals across Georgia, and again, looking at the baby, but they're realizing that it starts.
Yep.
So they were trying to figure out what they could do. I mean, it's a challenge.
It is. Yep. And then even by the time they're in the hospital or by the time they encounter the healthcare system, there's probably even a set of time before that, nutrition, nutrition and other things, right, as you grow up that are going to impact even before a young lady encounters the healthcare system.
Yeah. So it's a long journey for sure. So I think anything like this whole topic, whole person health.
I can talk about it forever. So
I know, but you're passionate about it. But the most important takeaway for our listeners, it's a long thing.
It is.
It's not a rapid turnaround of return.
It's not.
It's years. So that's probably why we've been so frustrated with it.
Yeah, exactly why we say because it takes so long to actually see the results. At a macro level, right? You see individual results right away, but at the macro level, it takes a long time to turn it around because that's how the system, that's how the system works right now.
Sure. Yeah, we are impatient people.
Mm-hmm.
So let's forward-cast a tiny bit. We're getting ready to enter, believe it or not, the second half of 26. Can't believe we're almost here.
Yeah.
Summer solstice is like, a few weeks away.
I know.
Let's look to the end of 26 and then maybe even to 27. Where do you see the data feeds? We talked about the challenges with the data gaps. So do we see that improving, number one? And then number two, do we see sort of this more focus on the whole person care as we head into sort of this next year?
I do think there are specific initiatives, specifically around at HHS and the federal government, which good, bad, or indifferent, it does set the stage for how we're going to perform and things that we're going to do. And so there are some really interesting ecosystems around the data side that CMS has kicked off and I think has some promise. It's not the first time we've kicked off a data ecosystem or data integration or APIs or all the other things that we are
HIEs, exchange,
right.
all things,
So,
right?
but it is another one. And so I have hope, given the advances in technology in general, that this has some legs to it. And so I think that one's really interested. I also think the rural health transformation, monies that are going to states, I think will help in the long term. I think in the short term, what I have found, states are using it for some interesting, quote unquote, rural things that are probably more infrastructure and won't move the needle a lot. But ideally, there'll be a second round of funding for that I think will really help states impact that rural health population who do have lots of access. One of our biggest concerns around access is there. So I think both of those are exciting. Again, I'm a little bit cautious because I've been doing this for 20 years as well. And I'm all supportive. I want it to work. And, we'll see. Right. And so I think they're exciting if they carry forward the way the vision is.
I had the chance to meet with a bunch of rural hospitals a couple weeks ago. And, the one thing that really inspires me always about the small community hospitals is the passion they have for their communities. Like speaking of community programs, right? They get it. I think the smaller hospitals get it maybe more than the bigger ones.
I think, I mean, it's their neighbor who's coming in, right? So there's something very different about having your neighbor come in and you're treating, your best friend's mom who's coming in who
Yeah.
just had a heart attack, right? And so I do think there's something very personal about it when you get to those rural places. And I think also in speaking with FHAQs as well as rural health hospitals, is they know they are the only stop there is, and so they feel very passionate about improving that patient at that moment, even if they aren't the long-term solution, because they are the only solution. And so instead of passing someone off saying, hey, you need to go see the cardiologist or you need to go do this, they're it. And so I think there is this level of passion around doing something for the individual, no matter, whether it's the directly impacting what they came in for now, but they want to take care of that person. And so, I think the fact that there's not resources also leads to people feeling really passionate about helping the people they can.
Yeah, I agree. Yeah, it's always inspiring when I hear the stories, that's for sure.
Yes, absolutely.
Speaking of inspiring, I am so inspired that you are a part of this company who is very much involved in our state programs and very much involved with helping communities through all the work that you do at Acentra. So, Meghan, just thank you so much for shedding a light on these issues, for that role of the community, the importance of data, and then also kind of, the whole person interventions, how we can get better at that to really improve our outcomes over time, right? And over time is another thing I learned today from you.
Yes. I appreciate the opportunity to talk about it. I think the more we talk about it, the more we bring interest to the topic, the more likely we are to solve it. And so I really appreciate the opportunity to speak on the topic and share some ideas. So thank you.
You got it. So for our listeners, you can connect with Meghan on LinkedIn.
That's right.
And learn more about Acentra and everything great, all the great stuff they're doing at Acentra.com.
That's
CENTRA.com. Meghan, thanks again for joining us and being on the show.
Awesome. Thank you very much for having me.
This has been Beth Friedman, Senior Partner at Finn Partners. Thank you for tuning in to Finn Voices, where we explore health information, health innovation, and all the technology in between. Until next time, wishing you all the best in health.
Finn Voices is brought to you by Finn Partners, a global marketing and communications agency working across industries and services. Whether inside our walls or on the front lines of health transformation, we stand together to create meaningful and measurable impact for the world around us. Learn more at finnpartners.com and follow us on LinkedIn at Finn Partners.